So I'd like to personally welcome first Doris Acevedo-Garcia. She's an associate director for the Institute on Urban Health Research at Northeastern University. We also have Nancy Eldridge, executive director of Cathedral Square Corporation, and the focus of one of the case studies that you have, hopefully that you have with you. We have Gavin Kennedy, a colleague of mine, who is the director of the long-term care policy at the U.S. Department of Health and Human Services. Jens Ludwig is a professor of social service administration, law and public policy at the University of Chicago Law School. We have Dr. Megan Sandell, a research scientist and pediatrician with Children's Health Watch. And we have Tom Slemmer, who's the president and CEO of National Church Residences. We've asked Professor Acevedo-Garcia to give the overview presentation. At that point, we will break into the conversation. So, Professor?
First, thank you very much to MacArthur, to the museum, and to HUD for the invitation to be here today. A couple of colleagues and I were talking during the day about how this effort was really started by Erica years and years ago when she did some planning sessions for coming up with an initiative like this. And I was very honored to be part of that from the beginning, and it's just wonderful to see that today we are such a large group of people and we are all kind of following this path together. So that's really important for me from a professional perspective. So thanks again. And I'm gonna do something similar to what Heather and Jeff did this morning, trying to present some of the evidence on how housing matters for health. And as Raphael said, this is a huge topic. I used to teach a course on housing and health issues, which I've now trying to broken down into 2 different courses because it's a huge topic. So you have to bear with me. I'm going to try to summarize not so much the research evidence, because I think as a panel we are going to be addressing that, but I'm going to summarize some of the main ideas I think are important to keep in mind for a discussion like this. So just to start, a few key points I want to make. I want to talk about housing as a social determinant of health. And for those of you that are not in the public health field, I'm going to explain in a minute what I mean by that. Then I'm going to talk about some of the research evidence, just in general terms, what it suggests in terms of what are all the different dimensions of housing that can affect health, and how, I think this is the really interesting part, how all of these dimensions of housing can be affected by policies, so we have a good opportunity to enhance health using housing policy. But the key really is how to strengthen some of those connections between housing policy and public health policy, which is, of course, part of the discussion that we are having today. So first of all, I want to present a really basic framework of what are the determinants of population health. Some of you may be already familiar with, but I think it's important to restate that our understanding in public health right now is that the traditional things that people associate with health, such as healthcare or health behaviors or genes and biology, are a relatively small component of what we are in terms of health over the life course. Social factors such as education, income level, and neighborhood conditions, as well as environmental factors such as pollution, are much more important determinants of health. So healthcare, of course, is an important piece, but I want you to keep in mind that housing can be linked to health through many other pathways, not just to the provision of healthcare. Another important thing I wanted to mention, and this is related to what Tom Cook was talking about just before me, is that we are really thinking about health in a life course perspective. That means that we are looking at all the different influences on the child, and of course the child is embedded in many different developmental or health contexts, the family being one of them, but the family is also embedded in a housing unit, in a family. Of course, there are many different decisions that people have to make, as Tom said, between the quality of the housing unit, the quality of the neighborhood, the quality of the school. And what is really important to keep in mind is that that housing choice that family makes, even if it's not explicitly, is also going to influence the type of neighborhood context and school context facing children. And all of those environments are very important determinants of health. And of course, that's going to play out across the life course, and that's going to influence who those children are going to become in terms of their health, their productivity, their educational attainment, etc. And I think that the last point I want to make is that the housing policy environment or the operation of housing markets are really the big picture in which those families are operating, making those choices. And that's where we have an opportunity to have policy levers that can influence population health. So trying to summarize a huge body of research, and I want to qualify saying that not all of the evidence is conclusive, and all my colleagues on the panel are going to be talking about the evidence later. So I just want to make a few points about all the different pathways or mechanisms in which housing can affect health. And I'm not even being exhaustive here, but I try to address the ones that are clearly going to be addressed during the panel discussion. So we have a lot of evidence on the quality of the housing unit in terms of the physical quality of the unit and health. People have mentioned lead poisoning several times during the day. That's a key connection. Another very important connection that Megan Sandell is going to be talking a lot more about today is the connection between housing affordability and health. Tom mentioned that a very important component of the Section 8 voucher, for example, is that it's an income supplement or an income shock, positive shock that families receive, and that has very important implications for health, among other reasons, because people are able to make better trade-offs if they have this income supplement. So affordability is a very important component of the picture. And finally, Megan is going to be talking a lot more about that from a child health perspective. Housing insecurity has been linked to health in a number of different ways. A lot of the evidence is about homelessness and poor physical and mental health. And I want to just qualify that that could also be a two-way street, homelessness leading to mental health issues, and of course the other way around. And it's very important to keep in mind that bidirectionality of health and housing as we discuss the rest of the topics today. And more recently, the University of Maryland just published a study, I think last week, on the relationship between foreclosures and depression in families. So I think that other aspect of housing insecurity is going to be very important going forward. The other aspect that Jens is going to be covering is the issue of neighborhood environment. Of course, we have the very recent findings from the new round of MTO research, which are very exciting, showing that neighborhood environment really matters for obesity and diabetes, and we had other findings from previous work. And the other panelists are going to be talking about housing as a platform for healthcare delivery. We have been talking about housing as a platform for delivering other services, which of course is also very important. But healthcare is a particularly important thing to discuss in the context of vulnerable populations that receive housing assistance. So we, in our research team, have been looking at some of the evidence linking Section 8 in particular and health. Pam Joshi, our policy research director that is in the audience, is leading this effort. And what I can tell you is a pretty daunting exercise to try to look at the evidence that Section 8 voucher may improve health outcomes. We've been engaged in this effort for months now, and I think there is some really good news. I think that there is some strong evidence from experimental designs that Section 8 has a positive effect on the health of really vulnerable populations, such as veterans, the mentally ill, the homeless, and people that have HIV and AIDS. So that's very good news. I also want to say that, in general, those experimental designs look at Section 8. At the same time, everyone in the control and experimental groups is receiving medical care as appropriate, and they are also receiving, the people in the control group, other forms of housing assistance. So, for example, transitional housing or shelters. So what these studies are really measuring is the effect of the Section 8 voucher itself. And it's fascinating to see that there are effects on health behaviors, clinical outcomes, transmission in the case of HIV/AIDS. So this is very strong evidence, very important evidence to point to. However, what we have discovered, and at the same time we have been frustrated about, is that we know a lot less about the effects of Section 8 on what we call the general population. So obviously, everyone receiving a Section 8 voucher, because of affordability issues, they are relatively vulnerable people. But we don't have more information about the health effects on people that are not at risk of homelessness, are not mentally ill, other groups that are not as vulnerable. And very importantly, from my perspective, we don't have enough information about the impact of Section 8 on children. We have some evidence from MTO, but MTO, as we all know here, had a locational constraint. So I think a lot more studies need to be done about the effectiveness of this general Section 8 program on child health and adult health. We have also looked at the evidence on housing mobility and health, and most of the evidence comes from the neighborhood and moving to opportunity experiment. But not only, there are some other studies that we have looked at, but I'm not going to address that in depth because Jens, of course, is going to be talking a lot today about the new findings about obesity and diabetes. And we also had the previous findings, which are important to mention, on mental health outcomes. So the first round of MTO health findings did find that moving to a low-poverty neighborhood improved mental health for adults and also for children or for youth. But there was an important gender effect or gender differential in which girls seemed to benefit, but boys didn't. And my colleague Teresa Osipuk at Northeastern University and a number of other people from the Harvard School of Public Health and Northeastern, we are engaged in reanalyzing some of the interim MTO findings because we're very intrigued by these gender differentials. And I just want to mention some of those findings really briefly here because they are under review right now. But what we looked at, it was at baseline, what was the vulnerability of the families that were involved in this intervention moving to opportunity. And we looked at the mental health family had mental health issues at baseline, also whether they had a member that had a disability at baseline, and whether they had been victims of crime at baseline. So we defined vulnerability in a number of different ways. And what we found is that the families that were vulnerable at baseline, those families really stood to gain a lot less in terms of mental health benefits than the families that were non-vulnerable. And that actually helps explain some of the gender differentials. So I think that's a very important finding because what it suggests, at least in my opinion, is that when we are thinking about opportunities in terms of neighborhood environment, we have to look at the situation of the families at baseline, and we should not assume that families can be moved to a different neighborhood if they are not given the right kind of supports to leave the old neighborhood, to transition into the new neighborhood successfully, and also to address some of the underlying issues that they are facing, including mental health and disability issues. So just a couple of things to keep in mind because we are trying to keep this panel very focused on the policy implications. So we are going to try to make a case that housing is a public health intervention. We talked about that during our conference call a few days ago, so this is a point that we want to make today. And what that means is that we have to think about health much more proactively as we plan, design, implement, evaluate housing policy. And in public health right now, there is this catchphrase which is health in all policies. That is informed by the Health Impact Assessment Framework, which means that in public health, we have relatively limited tools to address all the social determinants of health. So we have to look into the other fields, such as housing, to be able to do this work well. So that's what that means. One of the issues that I wanted to emphasize is that I think that we really need to work with families. People said that during the discussion about education and the discussion about employment. We need to work with families from the beginning and understanding what are the health needs that they have. And people mentioned data several times too during the morning discussion. We need to be able to track the family's health status over time and see what's happening with them. And finally, something that has not been mentioned today yet is that HUD is doing a lot of important work looking at this issue of using an opportunity index. And I think that it's going to be very important as we define opportunity neighborhoods to think more proactively about what that would look like in terms of opportunities for families to be healthy. So, for example, one of the components of the index that has developed recently is schools, which is a very important one. And I think key for children, but we can also define opportunity in even more concrete health terms, such as access to safe neighborhoods and also access to healthy food, walkability, etc. So I'm going to stop there and transition to the panel. Thank you very much.
Thank you, Professor. That was a very interesting and comprehensive review of a vast field, and I challenged her to do it in 10 minutes. Yeah. She actually came close, so that's impressive. What I thought I would do is sort of have each of you offer your reflections on how housing matters. And each of you comes to it from a different place and intersects. What I thought would be interesting is, as we go through each of the panelists, for you guys to think about reactions, similarities, cross-cutting. And so after we go through, I'll give you each an opportunity to talk about how what you've done relates to sort of what you've heard, and see if we can identify some places of interaction and perhaps future collaboration, coordination. And then we talked earlier about the idea of what's the evidence base and what's missing and what sorts of things we might want to do. And then ultimately, I'd love for us to spend a lot of time talking about policy and what sorts of things you think that folks like me should be taking back to principals and lawmakers to really make a change. Professor Acevedo started with she ended talking about practical. And so what I thought would be useful and interesting is to talk to the person who is perhaps the most practical on this, which is Nancy, who you're out there on the street doing this.
Most practical.
Doing this every day. I read in the case study that by your estimate, expanding Cathedral Square services would save something on the order of $40 million in Medicare. Where do these savings come from? How does this actually play out?
Sure. The $40 million is Medicare dollars alone. And what we did was we did a business case model that looked at 10 cost centers that all of the recipients of Medicare drive. So we looked at hospital inpatient costs, pharmacy, skilled nursing facility usage, and looking at the literature, looking at what we've seen works in terms of care management and care coordination and transitions planning. We projected, for example, that we would be able to reduce hospital admissions among Medicare beneficiaries by 17%. We projected that we would be able to bring down skilled nursing facility usage by 9%. And on the other hand, we also projected that there'll be an increase in certain service areas, particularly in home health. So that's the model. The basis for those projections lie in just what we heard, that the determinants of health have very little to do with the healthcare delivery system. 40% of the determinants have to do with behavior, 15% have to do with the environment you're in. And so we said to ourselves, well, we've got 200 subsidized housing facilities in Vermont alone. Public housing, tax credit housing, 202 housing. If we could embed care managers into all of those housing communities, not only to serve the residents, but to serve the surrounding neighbors, then we know we're going to get at the core of care management, which is all about self-management of chronic conditions, of transitions planning, of helping people communicate with the rest of the delivery system. So base to that 40 million is we have to have a completely integrated system that connects the hospital to the physician, to the area agency on aging, to the home health, to the houser. And if we don't fully integrate, we will not achieve those savings. And last, I would just say is our approach is all about systems change. It is not about changing one part of the system. It's going to require the housers really change their role and move from just a provider of housing to an advocate for their residents. So we're very excited. We have $10 million from Medicare that is funding 112 housing sites around the state. And in 3 years from now, we will have a rigorous set of outcomes data, and we will prove that we saved 40 million plus. Well,
I'm looking forward to that, because that will. I mean, we'll talk later about budgets, but I'd love to see that 40 million in the HUD budget. Mm-hmm. So I was wondering, in thinking about the how housing matters, you talked about the systems change. What sorts of things do you think are not happening now across the country that your systems change would provide insights on? If you have thoughts on that, Nancy.
I sure do. We're not connected. Our residents, they go into the emergency room, then they go for their 3-day hospital stay, then they go to the nursing home until Medicare is done paying for them. Then they come back to our housing. They inevitably spend a couple days where nothing's happening. So they've just gone from the most intense 24/7 support to literally arriving to our communities with a brown paper bag full of narcotics. They're usually pretty, medicated at that point. And they suffer from dehydration, from poor nutrition, from total mismanagement of their meds. So we drop the ball at the most critical moment. And so, true integration isn't just aggregating all the agencies and saying, play nice in the sandbox. It's saying play differently in the sandbox so that we are truly sharing payment, we're truly sharing responsibility for outcomes, and we are very much changing the way we work outside of our silos.
So that's very interesting. You mentioned nutrition, and Dr. Sandell, I know you've spent at least the last 12 years working on these sorts of issues. Talk a little bit about how you have found housing to be impacting food insecurity and other aspects of children's health.
Yeah. Great. Thank you very much for having us today. I'm here representing Children's Health Watch, and Children's Health Watch is a pediatric research center that studies how nutrition policy, housing policy, and energy policy impact particularly young children aged 0 to 3. And our research, much of it through the support of the MacArthur Foundation, has really found profound impacts on how housing policy impacts child health, child growth, and child development. And I think that what's interesting is we really try and look at the interaction of food and nutrition and housing and energy policy together, because for many families, they're not siloed, they're all interrelated. And I think what's really been striking for us is thinking about how a housing subsidy can actually protect a family that is experiencing hunger from their child having stunted growth as a result of that food insecurity. And I know you wouldn't necessarily connect those two, and yet that's what our research shows, is that there's a twofold protection for young children living in food insecure households when compared to families that are also food insecure but aren't receiving a housing subsidy even though they're eligible for it. I think for me, a lot of what the interaction that we're talking about here really drives the fact that young children are incredibly important because of their rapid brain growth and their rapid body growth. This is a critical window, and if you miss out on this critical window, when you think about kind of a life trajectory approach, small changes can really project over time, and you may not be able to make those up. And I think that that's really a crucial point. I think that what's interesting for our research is we focus not only on homelessness, but also this concept of housing insecurity, that there is more than just the fact that you're homeless, that you may be doubled up for economic reasons, overcrowded, or you may move 2 or more times in a year is how we define housing insecurity. And that in and of itself has been shown to be really profoundly influential on child health. And I think the third thing is that really a housing subsidy is a medical intervention. We've been invited to actually submit one of the blog postings after the conference, and the title of our blog posting is The Housing Vaccine. And I think that in many ways, when you think about a vaccine, you're really thinking about the lifelong benefit that you're going to be protected because of that. And so we say a housing subsidy that is literally a safe, decent, affordable home is like a vaccine. It will keep a child healthy. And I think that what's really exciting about this is the idea that you can see multiple benefits from a single intervention. The other thing that I want to kind of highlight is just that I think that I'm going to kind of anticipate the follow-up question, which is what policy solution I think would be really helpful. And in a lot of ways, many of what our research has shown is that if you receive a housing voucher, you are obviously protected from housing insecurity, but that if you receive that housing voucher and food stamps and WIC, if you're eligible for them, you are still statistically significantly protected against housing security versus a voucher alone. And so one policy kind of prescription can be many times the documentation that you prescribe or that you're needed to bring is the exact same documentation, but you have to bring it to 3 different places in order to get that done. And in many ways, the ability to cross-reference databases, being able to do a single application to receive multiple benefits, I think could be a really powerful intervention to make sure families get the full extent of the benefits of these subsidies and therefore improve child health.
Well, thank you very much for that. This coordination between programs is something I definitely want to talk to Gavin about, but not right now. So what I'd like to do, though, is you mentioned about moving and how housing insecurity translates into food insecurity. Yeah. We have an expert here who has been studying moving and what that means for people's housing as well as their health. Professor Ludwig, talk a little bit about the experiment, the demonstration, and then what you found and what the team has found in terms of the relationship between housing and health.
Sure, thanks. So I've been involved with HUD Moving Opportunity Study for 16 years. You might think, how can someone who looks 17?
I was about to say you were 5 at the time, so yeah.
Let's just leave that open as one of the big mysteries of the housing research community. I think most of the people who would spend a beautiful fall afternoon inside listening to housing research are probably familiar with MTO, but let me just say a minute for those of you who are not so familiar with what Moving Opportunity was. Starting in the 1990s, HUD enrolled about 4,500 low-income families. Most of these were female-headed households with children living in very distressed public housing communities in 5 U.S. cities: Baltimore, Boston, Chicago, LA, and New York. I live in Chicago now. The Chicago demonstration sites were the Robert Taylor homes on the State Street corridor that many of you will be familiar with from visits to Chicago. Extremely distressed baseline public housing communities. And then the women who signed up for MTO were randomly assigned to receive the opportunity to relocate to lower poverty neighborhoods with a housing voucher, and then there was a control group of families who didn't receive relocation assistance. MTO, in my view, did about as much as I could imagine any feasible housing intervention to do in helping families move to less economically distressed communities, and we can talk some more about that during the question and answer session. What we did with generous support from the MacArthur Foundation and HUD and the National Institutes of Health and many other funders is followed the moms and the kids in these households up about 10 to 15 years after baseline in the study. And we measured their health outcomes. Around 17% of the control group, the moms who were not offered relocation assistance in MTO, were extremely obese at the 10 to 15 year follow-up. So this is defined as having a body mass index. This is weight in kilograms divided by height in meters squared of 40 or more. As a way to think about what that means, the average height for a woman in the United States is about 5'4". A BMI of 40 or more corresponds to a weight of 235 pounds or more. Mm-hmm. So this is a severe risk factor for disease. About 17% of the control group women had a BMI of 40 or more. About 20% of the control group moms had diabetes at the long-term follow-up. And one of the important things that I want to mention here is we were able to measure diabetes prevalence in MTO by actually collecting blood samples. That turns out to be extremely important because research has shown that about 1/3 of people with diabetes in the United States don't know they have it. Mm-hmm. And I think I want to particularly thank our government technical representatives at HUD, Mark Schroeder and Todd Richardson, for their incredible efforts in facilitating the collection of the blood spot samples. What we found is the offer to move to a lower poverty neighborhood in MTO reduced the prevalence of extreme obesity and diabetes by about 1/5. Now, you might think to yourself, how should I think about whether that's a large or a small effect? One way to think about that is about the same size long-term effect on diabetes prevalence as what you see from medical interventions that were explicitly designed to reduce obesity and diabetes prevalence. like best practice lifestyle interventions and medication that's designed to reduce diabetes. So this is an extremely sizable impact from a housing intervention that wasn't intentionally designed to move health. And I think really reinforces the points that have come up over the course of the day about how health, the determinants of health extend far beyond what happens in a doctor's office.
So Jens, I actually think that that's an important point, that this was not really designed to look at health to start. What made you think about health? And sort of were there cues that you started to observe in the participants that made you think, hey, this is something we need to focus on?
I think one of the real turning points, I think, in the MTO research was very early, during the earliest days, the very first qualitative research on moving to opportunity families was carried out by a bunch of economists who are not known for actually going out into the field and talking to moms. So this was Jeff Kling and Larry Katz and Jeff Liebman. Before they went out and did their survey data collection, they talked to a bunch of the families in MTO in the Boston demonstration site. And I think that talking to families was really the earliest indication that health might turn out to be a much more important piece of the moving to opportunity story than anyone had anticipated going in.
So that's an important message about mixed methods of research and studying and making sure that we don't get too comfortable doing one approach, because there are things that we can learn that then can translate and inform other approaches. It's actually really, really interesting. I wanted to now go back to the policy issue that Dr. Sandell talked about and talk a bit about coordination between programs. And we talk a lot about housing as a platform, but ultimately you have to do it. And I think Nancy and Megan, you've both talked about this, doing it right and doing it well. Gavin, HHS is doing some work and really trying to understand that better. And I'm wondering if you have any thoughts on what efforts are needed to improve this coordination between housing and health policy, and also things that are really under your umbrella, like Medicare and Medicaid. What sorts of things might we be thinking about?
Well, this seems louder than I thought. Let me say, besides my loud voice, nothing's more disconcerting than knowing you have a 10-foot head on either side of you as you're speaking. Coordination is a big issue for us, and where housing fits into the mix. I would not say that we're new to housing and thinking about housing's role in health and long-term care, but this administration has really put an emphasis on not only the role of housing in health and long-term care, but in having a meaningful relationship and a coordinated relationship with HUD. So, my background is in long-term care, and so our interest is sort of what is the role of housing, particularly congregate housing, for older adults? Intuitively, it makes sense. There's an economies of scale that kind of already exists. There's an existing infrastructure. There's a concentration of people who, the platform is there. And just to compare that with, but there's little evidence about how that platform actually makes a difference in outcomes. There are a lot of great models. SASH is one of them that we need to look at and understand. But there really has not been a lot of rigorous scientific, empirical sort of studies of housing with services for older adults. But there's a lot that has been done around permanent supportive housing for people who are chronically homeless. And we're relatively new to this, and the evidence there is compelling. And we've been working closely with HUD on sort of learning, not taking what is already known about the impact of permanent supportive housing in terms of ending chronic homelessness, but sort of taking it to the next level, rolling in health reform. In 2014, everyone who is chronically homeless will essentially be covered by Medicaid. There's a surprisingly few number of people who are covered by Medicaid who are chronically homeless. So we're looking at 6 states really in depth over the next year, 6 communities rather in 6 states, to understand how they're using Medicaid to establish a sustained service funding stream for people in permanent supportive housing. Kind of jumping back to older adults, we have started actually we have a pretty great collaboration going now with HUD, with PD&R, where we want the evidence-based matters, and it's another thing that the Obama administration has really emphasized since day one, is that we want evidence-based policymaking. So, I expressed my skepticism about sort of the evidence that does exist around housing with services for older adults. So to that end, we've entered into a relationship with HUD, and we're supporting Leading Age and the Lewin Group to do a few things for us, ultimately with kind of demonstration design in mind. But knowing this crowd probably appreciates more than any how long demonstration and how long demonstrations take and how long empirical evidence takes to build. However, we remain on that path. But one of the key components of the collaboration is, surprisingly, for the first time, we're going to be matching HUD's administrative data with CMS's administrative claims data. So we'll be able to, in 12 cities, kind of understand who's living in HUD housing, what their healthcare use is, so we can really start informing who we're talking about, and then start talking about what sort of interventions we should be collaborating on. And then ultimately, again, taking advantage of some of the Affordable Care Act's new opportunities, plugging housing into the new world of service delivery reform, the shared savings models. Where do housers fit in this mix of providers? They are a part of the equation, but I think housers have not felt, I don't think they're as keyed into health reform and health care delivery generally, and I think there's a huge role for this sort of audience to kind of bring housers into that mix in a more meaningful, coordinated way.
Well, I'm hopeful that this has started to bring housers in. I know I'm much more informed about these things than I was when I started. So thank you for that. And I would really encourage everyone to go look and read up on this stuff, because it does make a difference. Tom, I wanted to sort of have you piggyback on the things that Gavin's been talking about, because you've been talking for a long time about how our current system of long-term care, particularly for seniors and how we fund, is not sustainable. How do we go about changing it? What are the things that we should be thinking about trying to put in place? And 5 minutes, so maybe the top 2 or 3 things that jump out.
Well, what I think National Church Residents can add to the discussion is we have a broad perspective on long-term care. We've been providing long-term care for seniors for 50 years. So while we have 20,000 plus affordable housing units, we also have nursing homes, assisted living, home health care, hospice, adult daycare, et cetera. So what we see, and we're also coming from Ohio, and in case anybody heard, Ohio had a very serious budget problem. And so if you think about Ohio as kind of a representation of what's happening around the country, in Ohio, for example, there are 2.3 million people on Medicaid, about 20% of our population. It was the biggest problem in the Ohio budget. About 35% of the Ohio budget goes to Medicaid, and we couldn't balance the budget. And so the cuts came basically in Medicaid, but about a $15.1 billion budget, 28% of it's Ohio, 72% federal. You can see the enormous problems related to the healthcare problems related to the deficit. So if you just kind of say the deficit problem is a healthcare problem, if you look at the Medicare graphs and you keep saying to yourself the deficit problem is a healthcare problem, the system we have is unsustainable because there's so many people coming into the system. So in Ohio, what we've done is analyze the Medicaid hotspots. Where are the places where you can impact most effectively, the cost? Well, 24% of Medicaid are the aged and disability category, and they use 68% of that $15.1 billion. 14% are dual eligibles, and they consume 34%. And in our system of affordable housing for seniors, about a third or more are duals. So we have a great opportunity within affordable housing to impact the cost. If you look at Medicare, which I think one of the big problems is the integration of Medicaid and Medicare has to work better to solve the problems. So things that the state do on the Medicaid side oftentimes benefits Medicare, and there's no reimbursement except in Vermont, where you've been able to solve that problem. So the current system doesn't work, and so you just fast forward that and say some change is going to happen. Where are where are the ways for us to impact cost in our system. And affordable housing for the homeless certainly works. If you look at behavioral disabilities driving healthcare costs, our most recent supportive housing facility for the homeless opened up. 71% had a diagnosis of mental illness. Now think about that. 6 came directly from a nursing home, 14 directly from a mental health institution. So you see, even if the research doesn't show you're impacting people while you're in the facility, it certainly shows you're able to take people out of a much higher cost setting. HUD has an affordable assisted living conversion program where we're able to convert affordable housing to a much more intensive use. I'm not sure it's the perfect solution, but the most recent one we just opened in Cuyahoga Falls, we had 18 out of the 26 came directly from a nursing home. HUD ought to be getting the credit for that because the cost to the state for a nursing home is $175 a day in Ohio, and the cost to the state for assisted living is about $70 a day. So I think what we're seeing is that the costs are unsustainable. Certainly there's a direct impact as you take people into affordable housing. We believe there's a lot of interventions, as Nancy's doing in affordable housing, can show really serious cost reductions.
So thank you for that, and I really appreciate the quantifying of the cost. It's one of the things that we've been trying to get a better handle on. Sort of, we know, to some extent there are improvements, but to say it's $100 a head, per month, that starts to add up, particularly in these tight budget times, and that's really, there's been a reshaping of the type of conversation we've had in Washington and clearly across state houses across the country. Dolores, I wanted to sort of come back to you. You gave us such a wonderful overview, but there's some work that you're doing about race and ethnicity and disparities in health outcomes in that context. Particularly for children. How does housing, talk a little bit about how housing fits into that, factors into the work you're doing, and then if you do have thoughts or reflections about some of the things you've heard from others, it'd be great to get some of that as well.
Sure. Well, first, a lot of my work has to do with racial and ethnic disparities in health, and I think maybe many people in the audience are familiar with the extent to which we have disparities, but it's, I think, important to restate that we have very significant racial disparities in health, in mortality, and also in child health outcomes in this country. Some of them are really long-standing, and we don't seem to be able to address them. We have been able to improve absolute levels, but we have not been able to reduce disparities as much as we would like to do. And that's definitely a public health priority. For example, our public health plan for the nation, Healthy People 2020, and 2010 as well, they have stated reducing disparities as the main issue. I think it's in a way interesting that I think that today in the discussion we have not talked about race explicitly. I think you kind of did in the morning when you mentioned that a lot of the issues around geography of opportunity have racial dimensions to them. And I was actually really fascinated to read the Regional Fair Housing and Equity Assessment for HUD that has been proposed now as a requirement for the Sustainable Communities Grantees. And a lot of people at HUD and also outside of the administration, we've been talking about creating some kind of opportunity index that allows us to allocate housing assistance in a way that is more equitable from a racial point of view. In my mind, I think that one of the main drivers of racial disparities in health is housing. If you look at any aspect of housing, from home ownership to lack of affordability burdens, to neighborhood location, and of course we've been talking the whole day about the strong correlation between neighborhood quality and school quality. If you think about how all those different contexts are really shaped not only along spatial lines but also racial lines in our country, and when you think about the issue of multiple layers of risk, so we know from the child development literature that Megan knows better than me that a child is much more likely to be resilient even if he or she has a challenging family environment, if he or she is also exposed to a challenging neighborhood and school environment at the same time. And we quantify that in a number of different ways. Just to give one numerical example, using 2000 census data. We haven't done that with the most recent data. If you think about the probability of a child being in a poor family and a poor neighborhood at the same time, which is, again, a measure of multiple risk, only 1% of white children in 2000 that were in a poor family also live in a poor neighborhood, defined as a neighborhood with a poverty rate of 20% or higher. However, that percent for African American kids and Latinos was more around 20%. So it's a huge disparity in neighborhood environment, in multiple risk, even when we account for family factors. So I really think that housing policy is a key lever for trying to address some of that. And I think it's, for me, incredibly encouraging to see that not only that 10 years ago when people talk about housing and health, a lot of people would have rolled their eyes like, what are you talking about? But not only that, but also in terms of the policy side, that now we have an administration that is talking about this racialized geography of opportunity and thinking about how to try to correct that using some of the policy tools that you guys have at your disposal. So I think that that's a good sign.
Well, thank you for the plug on the Fair Housing Equity Assessment. I try not to do too many commercials up here, but anyone else who wants to, thank you. No, it's really important. And so, do others have reactions from what we've heard thus far through the panel that they wanted to throw into the mix as we talk about these issues? And I'll open the floor.
Well, I just think it's interesting to think about when we talk about vulnerable populations. I think that's kind of now a new buzz phrase, is that often we're talking about elders and we're talking about kids. They're the people who spend the most time in the house, and they're the ones that are in these critical windows that can be expensive both in the long term for kids. So kids may not be a lot of the budget in terms of Medicaid or other things, but when you add in education costs and you add in lifetime achievement costs, they can be incredibly expensive. And then I think elders, when you're looking at healthcare costs, that can be a huge percentage of the budget. And so that in many ways, I think that housing matters to everyone, and I think that that's really important, but housing particularly matters to young children and to the elderly. And I think that being able to think of solutions that are going to matter to those populations, I think, become really crucial. I also think that it kind of belies the research agenda here in terms of coming up with evidence-based solutions. And really, I'm going to put a plug in as a pediatrician. I think young kids are really important, and I think that being able to show evidence base around young kids are crucial. And then I think the same thing around elders, being able to show evidence base around those two, I think, are particularly important as a priority research agenda.
And I would add people with behavioral health problems and substance use disorder are among those vulnerable populations for whom housing kind of obviously matters. The permanent supportive housing research is one of the more compelling pieces of social science. There isn't a lot of compelling social science often.
Hey, watch it, watch it. Not having that today.
But we did a little quick analysis, a lit review a couple months ago on the sort of evidence of cost savings from permanent supportive housing, and the range is from $1,300 per person to $30,000, and about 20 to 34% of those savings can be kind of tied back to Medicaid savings. About actually 20, and also about 20 to 40% of those savings can be tied back to mental health services. So housing as a platform for behavioral health and substance use services is kind of an amazingly compelling intervention that I think is worth kind of thinking more about.
I'm just struck by your data, Tom, and the key point, I think, when we talked on the phone is that we're not just talking about HUD housing and RD housing, we're talking about home, wherever that is, a mobile home park, a single-family home, wherever you put your head down at night, that's home. And we're talking about a strategy that's trying to engage everybody where they live. And if you look at the statistics we're seeing, 49% of our residents have some kind of cognitive impairment. So we're trying to deal with that population, and they're not going to move to a nursing home because nursing homes, at least in our state, are intentionally being closed or delicensed. So they're going to be in their home wherever that may be, and it's our job to figure out, systemically, how are we going to reach them in a way that connects us to all of healthcare reform. And I would just say that for us, one of the exciting areas is to take the opportunity we each have in our states to tap into the health information exchange as it's being designed and developed in your states, to make sure that your housing sites are broadband sites, that they are sites that are considered community anchor sites for your health information system. So you're as much a part of the communication loop as a hospital is, or a physician's office, or a home health agency. That if housing is really going to be at the table, it means being at the table in all aspects of reform.
The issue of mental health has come up. I wanted to just mention what Moving to Opportunity, the new results that came out, tell us about the ability of housing and neighborhoods to prevent the onset or affect the onset and prevalence of mental health problems as well. When we followed MTO families up 10 to 15 years after baseline, one of the things that we included on the long-term surveys were a very detailed battery of questions that are capable of identifying whether parents and kids in the household actually meet clinical criteria for mental health disorders. Ron Kessler at the Harvard Medical School was part of our research team, and he's one of these geniuses who can come up with some way to, in 3 questions, find out what. So I try to never answer more than 2 questions when I'm around Ron. What you see in the long-term, data is that fully 20% of the moms in the control group meet clinical criteria for depression. This is not to say that the other 80% of control moms are in good mental health, but fully 20% meet clinical criteria for being depressed, for having major depression. And if you look at the moms who move to lower poverty neighborhoods, moving to a lower poverty neighborhood reduces the prevalence of clinical depression by about 7 percentage points. That's about a third. That's a huge reduction in the prevalence of depression. We see similar impacts echoed among the female youth in these. So we also surveyed female youth who were 13 to 20 at the time of the long-term follow-up, and about 20% of the female youth, the teens, had ever had met clinical criteria for any sort of mood disorder, depression, but also anxiety. And moving to a lower poverty neighborhood reduces that prevalence by about half. So about 10 percentage point reduction off of a 20% control group prevalence. And so as we're thinking about the role of housing and assisting people with mental health disorders, other physical health problems, housing, I really like the language around housing as a vaccine, and we see evidence of that on the mental health side as well as the physical health side.
So I think this is a great sort of opportunity for us to seg into policy. We've been dabbles into it so far. I want you to reflect on if you had sort of the one policy that you had an opportunity to make law. Nobody got to veto. You could actually just do it. What would that be? And talk a little bit about why that would be the one that you would look to.
I think the one policy issue that would change the world overnight if somehow you could get a Medicaid reimbursement for housing. And I say that from experience. In Ohio, for example, we're participating in the Home Choice Program, trying to get people out of nursing homes into housing. Housing's full. Any housing with supportive services is full with waiting lists. I think senior housing in the country has a 10-year waiting list. We had a friend that's a consultant for the Kohler Goldwater system in New York City, and Bill Kelly and I took a drive up there to see it. They have a 2,000-bed nursing home with 400 people that they believe can be easily housed. Well, New York City has one of the worst housing problems. They can't get them out of a nursing home at $300 a day into housing at a fraction of the cost. So somehow being able to offset Medicaid payments for the housing piece, like it's done in assisted living and nursing homes, is really crucial to solving the production problem for affordable housing.
Very interesting. Others?
I would say I wanted to ask the Secretary Sebelius this morning, but they didn't pick my card. You know, this spring, 15 states are going to submit their proposals to integrate care for the duly eligible, those who are eligible for Medicaid and Medicare. And when CMS reviews those 15 applications, I hope their lens is a lens of looking at where those people live, because they are mostly in public housing or in Section 8 voucher housing or in 202 housing. So my policy wish is that, that every one of those 15 states has a central role for housers and community development corporations as a organized unit, not just one by one, but as an organized effort to do what Tom's saying, to be part of the delivery system in a very central way.
Professor?
I would do something about the Section 8 program, trying to enhance the mobility components of Section 8. I would focus the program much more on what we expect to be good opportunities for children. I would use an opportunity index, and I know that you guys are considering that, to allocate the voucher, maybe not for everyone, but at least for a subset of the population. Maybe it could be a demonstration initially, and we obviously should understand much better what good opportunities mean for children. We've been looking into the location of early childhood, high-quality early childhood education centers. There are huge geographic and racial disparities, so that would be an important component. Obviously, schools, and I know the HUD index also has a sub-index that addresses school environment or school performance. And I would also recognize the importance of what people have called comprehensive or enhanced mobility. So that is really giving people information about what the neighborhood choices are, and then trying to support them through the move process and once they are in the new neighborhood. I think it's kind of naive to expect that you can draw people in the new neighborhood and they're going to be able to benefit from the resources that they have available. That doesn't happen even to affluent families. It just takes a while to get adapted to a new environment, especially one that you may not perceive as particularly friendly initially. So that would be the one policy that I would address.
Thank you. We talk a lot about those issues in our building, and it's something that we are very, very interested in. Three other... Megan.
Well, I'm going to reiterate the being able to cross-eligible certain subsidies, but one of the interesting things that we've recently found in our most recent analyses is how housing policy can impact into the womb. And so one of the things that I think would be great is to think about, could there be set-asides among, say, Section 8 vouchers for pregnant women? Obviously, the waiting lists in most cities are 10 years, so that's not going to be helping out a pregnant woman. But on the other hand, being able to do it, because what we found is that being homeless during pregnancy resulted in a 50% increase in low birth weight deliveries and a 30% increase in preterm deliveries. Wow. And so when you think about that, a preterm delivery can cost $250,000 if a kid stays in a NICU for 2 months. That the ability to have some type of set-aside for that particularly high-risk group, I think would be really fascinating.
That's really, really interesting. Gavin, did you have
anything? Federal employees have policy fantasies?
I have fantasy. Well, I shouldn't put that on. Sorry about that. Absolutely.
I think, you know, I'm trying to think sort of from my perspective, what would, you know, we talked this morning about, I mean, there are kind of amazing collaborations happening between HUD and HHS, but at the end of the day, we do run up against the legislative silos in particular. And I think OMB gets it, as the secretaries mentioned, but I don't think that necessarily ends up translating into the budget process at the end of the day. So it would be nice to kind of figure out how someday we can, you know, all of the savings arguments that we're making about serving older adults better in congregate settings and serving people who are chronically homeless in housing, a lot of those savings arguments are across programs. And so how do you make shared savings more effective outside of the Medicare and the Medicaid program to other,
so that's
how do you pool these
Yeah, that's exactly right. And
in a meaningful way.
Not even across programs, but across authorizing and appropriating committees, right? So now we're talking about who has financial and monetary authorities, and how do you divvy credit up across those to provide incentives for us all to invest. I think that's a huge one. That's one of my wish lists. You know, if we could figure out that mechanism, or one that would be relatively transparent, that everyone gets to claim a little credit, that would be just an amazing thing. Jens, if you don't have one, that's fine. I wanted to make sure you had an opportunity.
The thing that I was going to mention is just, it's not a specific policy, but rather a sort of a larger objective for policy, is to make sure that our policy interventions appreciate the importance of neighborhood safety as a component of housing and the location of housing in the well-being of low-income families, especially low-income families living in some of the most distressed communities in the country. In the Moving to Opportunity sample, at baseline, HUD did surveys of the women enrolling their families and asked them what was the most important reason for being an MTO. And so economists who think about jobs said, of course it would be jobs, and the education researchers said, you're crazy, of course it's going to be the schools. And 3/4 of the moms said neighborhood safety was the first or second most important reason, so far and away the most important thing. I was just in New York City Public Housing Project last week doing home visits with the probation department, and we were riding an elevator down, and the probation guys say to this very nice woman on her way down in the elevator, what's it going? How are you like living here? How is everything going? She said, I got to get out of here. It's just way too dangerous. Mm-hmm. And this is in an environment in which crime rates in New York City are as low as they were when the Dutch first took over the island. Mm-hmm. Right? There are still these pockets of the city where it's so dangerous, and this is such an important part of the well-being for families, and not losing sight of that as we think about the different mechanisms through which housing changes and neighborhood changes can improve the well-being of poor families.
That's such a critical issue, and I would just note that in the work that we've been trying to do around this, finding good quality neighborhood level information on public safety is extremely difficult, and it's very spotty across the country. This is an area where I think there's a large potential for improvement, which should get us to much better policy. I'm going to ask one more question of the panel before we open it up to the floor. So I hope you're getting your questions ready, and we will turn to them in a second. But I wanted to just get your thoughts on one thing. From almost the first day I was at HUD, Deputy Secretary Ron Sims and then Secretary Donovan, who was here earlier, continually talk about, a zip code should not be a determinant of your life trajectory. And when people choose housing, to some extent, they're choosing the zip code. How does your work inform that, or how does that reality inform the things that you're working on? And if you have quick reflections on ways that we might break that link, I'd really love to get your insights on that.
Well, it's interesting. I do think that on some level, it's sad that we can state that so definitively, that if I know your zip code, I know what your health is. And I've heard Secretary Sims say that. I think that this may be where we need to be more innovative about what data we have available. So one of the ideas that we've been thinking through and experimenting with at the hospital I work at Boston Medical Center is that as we convert more and more to electronic health records, we're going to have a repository of amazingly diverse and to the address level health data that, particularly at Boston Medical Center, where we've got 10 community health centers in our hospital on the same electronic record for 10 years, that our ability to do incredible data searches, and obviously that we need to think through the confidentiality and being able to do it, but that there may be some resources where we have to do a longitudinal study and we have to prospectively follow people and we have to introduce a randomized component, because these are really important things that we're going to have to control for and control for things we're not even sure of. But on the other hand, being able to access new forms of data that will be available, I think will help us to search through those distinctions. I think that a lot of what the research to date is around what the zip code is that you have to move someone to a new zip code. That's the intervention, is that you move out of it. And I'm not sure we quite understand yet how to make a certain zip code different to change the health. I think we're still, I think we know kind of in the apple pie way, like it's safe and you have a nice school and you can walk and you can have green space, but when you're getting kind of rubber to the road, what's the real prescription? I think that is where I think we're going to have to do a lot more data searching, a lot more understanding, mixed method, qualitative, and other things to try and research that.
Yeah, I just want to underscore the great importance of learning more about the mechanisms through which the housing units and the surrounding neighborhood environments affect health and other outcomes for families. If you think about the obesity, diabetes results, and MTO is a fantastic study, but it's less great in helping us figure out exactly what specific aspect of the housing or neighborhood environment matters most. For obesity and diabetes, it could be diet, it could be so opportunities for healthy food, opportunities for physical activity, access to medical treatment, or neighborhood safety are the four most obvious mechanisms that I can think of. One answer might be, let's just fix all four of those things, but about 200 yards that way, there are 8 people in a room trying to think of how to slash $1.5 trillion from the federal budget over the next 10 years. And so learning more about where the greatest social good can come from the marginal $1 million, I think, is incredibly important.
Nobody's leaving their zip code, and it's going to get worse. And so it's all about shifting the dollars that are at the hospital and in the nursing homes to the zip code, and it's about moving the supports to people in zip codes from the physician's office to the housing or to the community. It's about pushing it down because it will save money. It will save millions of dollars. We've already seen that. We've seen a 19% reduction in hospital admissions in Vermont. We've seen falls cut in half. And it has to do with human presence. It has to do with somebody being there. And so, you know, I think we're just in store for a massive shifting of resources back to home, and at the same time, better health, better care, lower costs. Triple aim.
This is, I can sort of shamelessly plug the HUD-HHS data match that I mentioned here because one of the driving interests is understanding by zip code what older adults in publicly assisted housing look like, what their characteristics are and what their healthcare use patterns are, and comparing that group with the surrounding community. So those are sort of the basic analyticals, but it's going to be a great foundation for probably doing a lot more analysis beyond the specific
that's
initial
the hope
description.
For sure, absolutely.
I would just say be a little careful about the discussions about the transportable nature of Section 8, because project-based Section 8 allows you to build facilities where you can aggregate services. So there's a lot of supportive housing for the homeless that are not in the best zip codes, but are providing great outcomes because they're able to aggregate case management, provide the right kind of structure, building, security, and those kind of things. So I think there is more that you can do efficiently in a facility than you can as you try to deliver care in individual homes around town. So just a perspective.
So I think that's a good point. And I think it gets back to where we started, which is that this is such a large field, and each population has its own realities that we've got to make sure that the policy approaches are tailored to that. Professor?
Yeah, I completely agree with the need to understand better what is exactly about neighborhood environment that matters for health. But on the other hand, I think that we do have enough information, first of all, on the very different racial realities or racial patterns in terms of neighborhood and school quality. On the other hand, we do have information, Jens mentioned the issue of neighborhood safety being a very important determinant of health and well-being outcomes. I think that we could definitely improve, again, the ability of especially housing assistance policy to link people to better neighborhoods and better schools. I don't see a problem with embedding that kind of effort into a demonstration so that at the same time we understand better what type of data to collect and whether that's being effective or not. But I think that assuming that we have to take for granted these disparities and work around them doesn't sound like a good idea to me. I think that we have to do something to address them.
All right. So I want to now open this up. If people have questions, please do approach the mics, and we can start to talk about the things that are on your mind. Please, thank you.
Hi, Gina Kwatrocki again. First of all, I want to thank you, Assistant Secretary. I'm also on the board of the National AIDS Housing Coalition. We appreciate you coming to speak in New Orleans last month for the 6th HIV/AIDS Housing and Healthcare Summit.
It was a great event.
Yeah, we've been thinking about this. Housing and AIDS housing providers have been thinking about these issues for over 25 years now. But one thing I want to talk about, and I guess this is a HUD-HHS thing, there's tremendous opportunity under the Affordable Care Act to achieve some of the things we've spoken about today, yet one of the new initiatives where the city and states will save a lot of money for 2 years because the feds are going to pay for the Medicaid costs for frequent users of high-end care, Medicaid recipients, under this new health home model. Nothing to do with home care, as you all know, but other people may not. It's a care coordination model. Right. And yesterday, it was implemented in New York City, in New York State, actually, under former HUD Secretary Andrew Cuomo and the Medicaid redesign team. And as an AIDS provider of Medicaid-funded case management and an AIDS housing provider, we started working on this new model today. It's a very fluid model right now. The State Department of Health is, I think, trying to figure it out. But there is no intersection, none at all, between this care coordination model and housing. None at all. In fact, housing connection, housing assistance, housing resource ID is not even going to be a billable activity in this care coordination model, yet those agencies, like mine potentially, that are lead agencies in the health home model are responsible for the health outcomes of the people that we're going to be working with, and yet we can't get paid for the housing part.
So this is a huge issue.
Huge.
I mean, I feel like this panel was about a year too late in terms of helping, in terms of the design of this, and it's very consistent with the systems change that Nancy was talking about. So thank you for that. I will say the HIV/AIDS housing area is one where the potential gains and the efficiencies are so dramatic and so drastic that we need to pay much more attention to that.
Right. So, and I really want to advocate, though, because the health home model is going to be used for all frequent users of Medicaid.
I agree with that completely. Okay. And so we should maybe 3 or 4 years from now.
I cornered the secretary on his way out.
We'll be able to get on that. Yes, next question.
I had 2 thoughts listening to this panel because
and you are first.
I'm Seema Iyer from the University of Baltimore. And the first one is that if we are going to deconcentrate poverty in an MTO-style model where we're trying to put people in places that are low to moderate poverty, the receiving communities obviously are the barrier in the vast majority of cases because housing policy is so localized and not done in any kind of regional capacity. So in some ways, we all need to learn to get along across income levels, across faiths, across all kinds of ways. And I don't see that happening anywhere. And obviously, the Brookings Institution has done a lot of research that we're actually becoming more balkanized, not just with respect to class, but with respect to race and ethnicity. So we're becoming a more segregated nation across all kinds of indicators. And I was wondering if anybody knew of anything with respect to community building on making us all get along if we really want to make this happen. But the other thing that came to me as I never heard this term of housing as a vaccine.
I have to make this relatively quick.
Housing as a vaccine. Do we just not have enough housing vouchers? And if you could, as the HUD, determine if we could get everybody off the waiting lists that are on it, how much that would cost, what would the health savings be? And you facetiously said, I'd take the $40 million from HHS and put it in HUD, but isn't that exactly
I was not facetious at all.
But isn't that exactly what you're saying?
No, so that's an interesting question, and there have been estimates of that, and it's a large number relative to where we are today and from a budget perspective. But it is something to think about in terms of how we might have a more integrated budgeting process and consideration on that, because the savings from doing these are substantial. I wanted to sort of also get to Seema's first question about local neighborhoods and how there's local decision making that is overlaid on all of this. You know, what do you have reflections or thoughts about how we deal with that as a barrier in the places where that might come up?
I would just say that everything we're talking about needs to be consumer directed, and if you really engage the community that you're trying to help, you're going to create a program that is supported by the community and really addresses the real needs and not something we think can meet their needs. So I think it's engagement at every level and collaboration among agencies, which is tough.
Yes?
Yeah.
So,
sorry, go ahead.
No, go ahead.
I was just going to say, this is where, being a pediatrician, I come at it from both a research perspective and then also from a patient perspective. And many of my families, when they get a Section 8 voucher, and I'd really encourage them to try and move to a different neighborhood, oftentimes they like to choose to stay in a neighborhood where there are people who look like them. And that self-segregation is something that I think is really interesting. And in MTO, when they unregulated the vouchers, many of them did move out of a neighborhood back to a more segregated neighborhood. And so that I still think our understanding of what people choose and how people want to do those things is as important. And I don't want to underscore, I do think it's incredibly important to create policies on the local level, but there also is the choice aspect of it that I think is really interesting, and one that if I could get another degree, I would get a sociology degree and learn more about why people are making those choices.
But I would also just piggyback on that to say that this is why, you know, mobility alone is not going to get it done, and a lot of the conversations about trying to find ways to change the neighborhoods to make them more conducive to positive outcomes is going to be really important. Jens, did you have?
No, I agree with that. I was just going to say, too, that one, as an economist who works at the University of Chicago, I'm not the person to ask about how you make people all get along. But the main thing that I wanted to say is, if you think about the logic of MTO, one of the reasons that we think MTO might be beneficial for the families who are moving out of very distressed communities into less distressed areas is peer influences. So being around more advantaged, less at-risk people might be beneficial for your outcomes. It is a probably not politically appealing possibility in this room, but logically it's not a crazy idea to think that if it is good for you to move out of a neighborhood where there are a lot of high-risk people, then it could, in principle, not be great for the people in the destination areas when you have more high-risk people moving in. And if you believe that research has a role to play in shaping people's thinking about this, I think it's extremely important for us to develop a better research base that lets us think about what the overall system-level effects are of resorting people to say that it's not just good for the movers. One of the research literatures that we do have that tells us something about those system-level effects is to look at what happened when big urban school systems were forced by courts to desegregate, where you had kids mixing up. And John Gurion at Northwestern has a great paper showing that when you force schools to desegregate, dropout rates for African-American kids go down and don't change for whites, which I think speaks to this issue of whether destination communities, whether it's a zero-sum game or whether there is some sort of net gain from this. And I think we need a lot more research along those lines as part of the effort to try and inform those types of destination community concerns.
Thank you. Next question.
Yeah, this is more of a comment. I'm Robin Stone from Leading Age, and I wanted to build on the AIDS provider issue and also to make a point that I think one of the things that we need to do here is to make sure we understand our populations, and not all of these solutions are the same for all populations. And I would argue, for example, that it hasn't been tested, but I don't think vouchers for elderly are probably going to be a good idea. In fact, you need more concentrations of elderly, and elderly pre-select to actually be in more age-segregated environments. We have 30 years of history on and research on that. So understanding the populations in terms of solutions, I think, are really important. And, you know, I always am on my hobby horse around elderly because this is the first discussion of the whole day that we've had around the elderly population. It seems as though elderly are not part of a family, which, you know, to my mind, I don't get, having worked on this for 35 years, but,
So
but it is an important group.
Yeah, I actually don't think that's true, and I would say, particularly given the demographics of this country.
I'm hoping we're realizing it because we're moving in that direction.
We definitely realize it, and you know, every day in my building, and I'm sure you know in Gavin's group and at universities across the country, this is just something that everyone is talking about. So.
The other thing I did want to say, however, is that it's not too late around integrated models through the ACA, and I think that there is room for HUD to have discussions with HHS around influencing not just the 15 state demos through CMS, but actually all of the states, or most of the states, are coming in with plans. And it is true, Nancy already has Medicaid dollars through a capitation. She has Medicare dollars that are going through a primary care home health model, medical home model, to support a service coordinator and a wellness nurse in every single one of her housing properties. She is a houser who has been able to get Medicare dollars. So we have the potential to do that. It's a matter of actually expressing this policy direction quickly, because there's
I don't disagree with you. I'm sorry we have a bunch of people lined up. But this is a conversation we definitely need to have.
Yes,
and it's one that, you know, this conference, frankly, helps to facilitate. So thank you for your reflections, and we'll try to make that happen. Mark?
Mark Schroeder, PD&R, and actually my question's for Dr. Sandell. If you had a patient come to you who was malnourished, you would prescribe food.
Yeah.
And if somebody questioned that, like your local Medicaid agency, you would show them the place in the textbook where it says that food is a solution for malnutrition.
Yeah.
What would you do about it? What's the point at which housing gets into your textbook?
Yeah, no, I think it's a great question. I will say, for many of you who are familiar, Dr. Jack Geiger, who's the founder of the Community Health Center movement, has a famous saying, which is, the last time I checked my textbooks, the cure for hunger was food. And so he actually wrote prescriptions from his community health center for food to go have it be taken in. And it's interesting, as Dolores said, I've been interested in housing since I was a pediatric intern, and I have often said that the best medical intervention that I can do for my families is to get them a safe, decent, affordable home. And it's been recent that I've been trying to think about a new frame, so I've come up with housing as a vaccine, partly because I think in the healthcare realm, we don't question vaccines very much. They are kind of a universal good, and we are introducing new ones all the time. And the return on investment for a vaccine in terms of lost work days for parents and lost days for kids at school ends up being kind of a no-brainer, and we kind of sign off on new vaccines all the time. And I actually think we have the return on investment data on housing, and yet we have a hard time still getting the silos of investment to do it. I think that it is interesting, and I think that when we think about ways to demonstrate the impact, I do think we're going to, in a new world where we're going to end up with capitated rates, no matter whether you call it something different, it's capitation. You're going to get a lump sum of money. Then you're going to start thinking about the fact that a lot of ways to make your population healthy are outside of the clinic, just as Jens said, and are things that are going to have to be about housing. I actually came to housing from a conditions point of view. I was caring about the cockroaches and the mice and the mold in the homes, and I think that more and more it's very clear that it's not a healthy home if it isn't an affordable home. And I think that, so when I talk about it as a safe, decent, affordable home that's in a neighborhood that is safe and that it has other things that are ability, because it's more than just the bricks or mortar. And I will say that I'm slowly getting my pediatric and medical colleagues to acknowledge it, but I do think that we're going to have to come up with the right frames in order to make the investment happen that's going to be really necessary.
Well, hopefully together we can all work to bring the AMA with us. Next question.
Hi, my name is Nellie Gorbea, and I'm with Housing Works Rhode Island. And I fully appreciate that we're at a national conference, and we have so many HUD people that it's great to be able to listen in on the national conversation. But I sit here from a state and local perspective, particularly since Rhode Island is so small. And so I'm thinking about, I would like to ask the panel for some thoughts on, of the policy suggestions that you're making sort of in this great sort of national sort of perspective, which ones would you sort of say, okay, this is something you could do at a state level to reconfigure programs that might be a little bit quicker than things that we could do at the national or federal level, and might yet help us get to where we want to go?
I do think, kind of going back to the very first question about health homes, the new state Medicaid option, as one example of some of the reforms in Medicaid that are in effect now that can be capitalized on. I don't understand the particular issue that they're having in New York, because I don't think there's anything precluding the health home option being structured to include housing as part of that coordinated system. But I think, kind of thinking about the ACA, and there's a lot of new flexibility related to long-term care service delivery that is in the ACA that really states drive. You know, the statute lays out what's allowed, and then states make the decisions. So there's a lot in the ACA that I think is currently authorized and can be availed.
Rhode Island is one of the multiple payer advanced primary care practice states. There are 8 of them, and our projects, Vermont's one of them. We started in October. We've got 3 years before Secretary Sebelius can make those permanent. If I were you, I would be organizing all the housers in my state to make sure that when that MAPCP demo becomes permanent, housers are a Medicare recipient of the payment.
I think it's a great idea on the state level. States are really interested in this because they have to balance their budget. They're looking at this. We have a dual eligible demonstration with housing in it. We just received a grant from a foundation, us in the state of Ohio, to come up with a production program for housing. I mean, they're looking to save money and do it in a way that provides good outcomes. So I think states are a good place to go.
All right, we have time for exactly one more question, so you're it.
Terrific, thanks. My name's Jim Dunn, and I work at McMaster University, which is in Canada, but I'm a visiting professor at Harvard right now. So I come at this from a little bit of a different angle, and what I want to ask is about the neighborhood, improving neighborhoods question. I'm going to do it with a metaphor. So I work kind of at the intersection of urban geography, housing, and epidemiology. And a very prominent epidemiologist named Len Syme worked on a major study called the Mr. Fit trial, the multiple risk factor intervention trial, for a decade of his career. And it was to identify ways to get people to change their behavior, essentially, in well-known risk factors, diet, exercise, that sort of thing, quitting smoking and that kind of stuff. They spent $40,000 per person in this trial to try and get people to change their behaviors, and achieved nothing. Mm-hmm. Len himself, actually became trained to do smoking cessation. And he said after many years of, some successes, mostly failures, he realized that for every person he actually persuaded to change smoking, there were probably 2 teenagers taking their first initial puff on a cigarette. So I'm using this as a metaphor to say, for every time we say, oh, these families don't have access to good schools, let's move them to neighborhoods where good schools are. For every time we say, oh, these families have concentrated poverty and safety problems, let's move them to safer neighborhoods, we're doing absolutely nothing to address where these bad neighborhoods come from and what are the forces that create bad neighborhoods. We have school districts that are highly dependent on own source revenues for their services, so they have a high concentration of affluent families. They have some school districts have high concentration of affluent families, a high tax base, great schools, et cetera, et cetera. You know where I'm going.
Because this is the last question,
sure.
But I actually disagree with you in a pretty fundamental way.
Right.
But we don't have time to go through all that, so
look forward to talking to you about that.
I do think we should carry this on more. I wanted to know if people have last comments they'd want to offer before we have to close up.
I think Medicaid has to consider housing as part of their toolbox of services, period. And the same with Medicare. I mean, we're looking at Medicare with, I think 25% of the population spends almost 85%. So there's got to be ways of using the whole toolbox, including housing, to solve the problem.
Well, thank you. I think that is a nice exclamation point on the notion of housing as a health intervention. Please thank our panelists. This has been a really wonderful conversation.